私、日本プライマリ連合学会の国際委員会担当常任理事をしております吉田と申します。どうもよろしくお願いします。はい。で、今日はですね、こちらにいらっしゃる、マルコ・モッタ氏をお迎えしまして、英国における薬剤師の役割の進化というプレゼンテーションを1時間ほどしてもらいたいと思います。で、モッタさんの方から結構気遣いをいただいてまして、もうスライドは、この AI で日本語訳したものを見せますと。ただ、英語で説明して、通訳で橋本先生も、入ってくれますので、なんか橋本先生ここにはまっててもらえますか？そんな感じで、英語と日本語で、英語を見せて日本語でやっていこうと思います。なお、モッタ先生が、ものすごく張り切ってですね、スライドがすごい分量なので、今からですね、英語のスライドをですね、皆さん、英語と日本語のスライドをチャットで送ります。これはちゃんと著作権というか共有可能ですよって、モッタさんに許可をいただいてますので、皆さん、これを見ながらですね、お手元で見ながらやっていってください。はい。ここまでよろしいでしょうか。あと、ちょっとズームの方がですね、私の仕様のものなので、あんまりオーディオとかですね、こだわっていないので、ちょっとお聞き取りづらかったら、チャットなどで、言っていただければですね、適宜対応します。ちょっと全部追い切れなかったらごめんなさい。あと、どんどん入ってきていらっしゃる方もいますけど、これも気づいたら入れていきますので、よろしくお願いします。そしたらこれで大丈夫かな。これ自分がね、どういうふうに見えているかがもうわかんないですね。はい。OK。OK、マルコさん。そう、はい。So, Marco, so could you introduce yourself to the audience here and the audience over this teleconference system?
Yeah. こんにちは、私はマルコです。はい。That's it. And this is my limit with Japanese. すみません。I'm basically, I work in England. I live and work in England, and I wanted to learn the Japanese system, healthcare system in Japan. When I was in England, I started researching about the Japanese healthcare system, and I realized you don't have a GP practice system, which in England and the UK are the fundamental of the patient healthcare. So I wanted to understand how you do care to your patient without a GP practice. And so I've asked to the Yoshida Sensei. I contact Yoshida Sensei organization, and he invited me to come and spend some time in Okinawa with the Tamaki-san, a pharmacist there, and then here with the Yoshida Sensei at the hospital to learn about the Japanese healthcare system. I'll go next slide.
Next slide.
Okay. This is a slide just who I am. So I'm a toxicologist and a pharmacist. I'm a mix. I'm part Italian, part from Czechoslovakia. I'm British as well. And because I needed to do 100%, I added 1% Japanese because I love Japan. I was working before as the chief pharmacist in the NHS for my area. So I was in charge of the primary care budget that was more than 120 millions of pounds, oversee the hospital budget, which was around 80 millions, and also supporting community pharmacy with the local services and also national services. I'm an independent prescriber and a clinical pharmacist. I'm going to explain later what does it mean independent prescriber. But in short, I can diagnose and prescribe like a GP, like a doctor. I publish a lot of papers because I'm really interested in research. And every piece of work I've done in my job, I then did a publication because it's good to share with everyone ideas so that you can learn from others and you can share what good ideas you're doing. And I've worked in Tonga, in the Kingdom of Tonga, in a remote island of Vavau. So I'm experienced of working abroad in different environment in remote area. And I was also interested in alternative medicine. So I traveled a little bit in Asia. And I've done many different jobs in many different area, not only pharmacy, but multi. And I try to give you an example of the area where I live. So it looks like Nara prefecture for how big is, or Kochi, Tokushima for the number of people that they live in my area. Quite small, very rural. And I'm also a politician. I'm a town councillor. So I'm also involved with my community from this part.
大体わかりましたかね。あ、すいません。今、すごい多様な自己紹介いただいたんですけど、OK ですかね。いい
大丈夫。
あ、じゃあ、ちょっと皆さんがあんまり分量が多くなったら、時々橋本先生が来て、日本語でまとめてくれます。OK。
Okay.
Okay. So, yeah, in some chance to, switch to him and some summary in Japanese. Yeah.
Oh, okay. I'm sorry.
Okay.
最初の自己紹介のところだけ、ここ自己紹介の今のところはいいとしてですね、やはりその日本の GP システムが、その NHS ほど、のシステムがないにもかかわらず、この、プライマリケアをここまで発展させられているっていうことが、すごく興味があります。なので、沖縄含めて、こちらの、海田病院にも、訪れさせていただいて、勉強させていただいて、皆さんといろいろとシェアをさせていただきたいという話を最初されてました。で、先ほどの話は、書かれている通りになりますので、いろいろとタウンカウンシラーとかも含めていろいろ本当にされてるんだなというふうに思いましたので、興味深くちょっと聞かせていただこうと思っています。
で、ごめんね。あと、
just a quick the slide. This is I finished with the NHS and I'm starting 3 new jobs, which 2 are still linked with the NHS. One is supporting community pharmacy. One is supporting doctors. And one instead is a private business about private healthcare and private clinics, which they have doctors inside and also a pharmacy in a new model of care. Next slide. So this is just why Marco you came? Why you came in Japan? Sounds quite like strange, but the learning priorities for me in Japan were in Okinawa City. Visit was to understand how community pharmacy workflow works. So about your dispensing, your robotics. Then I also wanted to learn the Kakarizuke Yakuzaishi model for pharmacists that they are basically involved with the home, with the family, how hospital and community pharmacy are integrated, how community pharmacy are evolving because the aging population of Japan is increasing. How is your digital system and the information flow across clinics and hospital, and also how people think about the role of community pharmacist. That one was my sort of learning, and I need to say domo arigatou gozaimashita to Tamaki-san in Midori Pharmacy, because it's been really good, and he gave me 2 weeks of amazing experience. So arigatou, Tamaki-san. And the next slide is about my visit here in Hizuka, and understand with the hospital about how is the hospital pharmacy, how is the flow of patients without a GP practice, because I was really interested, like, how is possible? So there were a few things that I wanted to learn, and how hospital and community pharmacy are integrated. Like, for example, they go out and do home clinics together, and also the digital system between hospital and community pharmacy. So this was the sort of learning that I wanted to discuss with Yoshida Sensei. So domo arigatou gozaimashita, Yoshida Sensei. So the next slide. Next slide is why I'm here. So I want to show how is the pharmacy model in England. Some of the innovation we do in my area, which is Cornwall. Cornwall is where I live. And I think we can learn between Japan and England, and we can carry on and sharing how we work, and we can inspire transformation. So pharmacists can also develop more skills and be more part of the healthcare system with the new services. This is just a picture of how a town in my area looks like. So very rural, fishermen that they go fishing, surfing, easy life, sheep, and cows. Yeah, mainly this. Okay. These slides explain a little bit the NHS. So the NHS means National Health System, is basically the government give the function of the healthcare to the NHS, and the NHS is free. Everything is free. So you don't pay for examination, you don't pay for test, you don't pay for medicine in the hospital. Everything is totally free, and you can be admitted, everyone can be admitted to hospital. So everyone is open to go with no charges, which is slightly different than Japan, because you've got an insurance system and 4 different categories, how you charge basically for your healthcare. The next point is the NHS is so big that gives some function to their own area. So in my case, I was in charge of Cornwall Integrated Care Board, is basically the government body that support England body to financially and with the clinical regulation for their area. And then everything is broken in small parts. So my area then it was broken in integrated neighborhood teams, primary care networks, and then in GP practice. So it's very structured system. And this one allows that every area can make adjustments, because maybe your area has more people with one condition, another area are more people with another different condition. And so every area can also work towards different priorities and unmet needs of the population. And also community pharmacy are really important because they are more community pharmacy than GP practice. And also we have a big digital system where there's a lot of connectivity across the system, and you got your NHS app where you can order your medication, order when you go to see a doctor, and see your test all on your phone. This is my area. This is a map of my area, and basically we have only one main acute hospital. We have around 10 small community hospitals. There are 55 GP practice. So GP practice is where you have maybe 2, 3, 5, 10 general practitioners, like family doctors, working together for their community. And there might be nurses, paramedics, pharmacists, a multidisciplinary team providing the care for their population that is registered with that practice. And there are around 100 pharmacies. This is just to explain that the NHS and the system in England decided to shift more the role of pharmacists from stay in the dispensing area to do more clinical care, more services for the patient, many different roles of pharmacists. The national healthcare, the NHS England gives a lot of national services to the community pharmacists. We are also independent prescribers, so we can visit, diagnose, and prescribe as doctors in specific areas that you specialize, and then you can evolve your role to cover many other areas. And because of that one, we work very with everyone across the system. This is a slide around the education. So it's a 4 years degree, 1 year practicing. Then you can do different post-qualification, like clinical pharmacist, independent prescribing, or you can then become even a consultant pharmacist in hospital, which is very high. So doctors goes also to the consultant pharmacist to ask for advice, and they follow what the consultant pharmacists tell the doctors, because it's very high specialized. You okay? Yeah.
今のところだけちょっと解説入れさせてください。さっきのは薬学部のシステムですね。で、薬学部はイギリスはなんか4年生のシステムを卒業してから、1年の、その現場での実習、インターンがあって、で、そこから、これからお話しされる、独立した、薬剤師、インディペンデントプレスクライバーの話されるんですけれども、それが、その権限が移譲されて、っていう話ですね、を、されるので、ぜひ、ここからよろしくお願いします。ありがとう。
So our UK model, United Kingdom is broken in 4 nations. There is England, Scotland, Wales, and Northern Ireland. But sometimes they are different. They do things in a different way. But independent prescribing, for example, is all across the United Kingdom. Sometimes things are slightly different. Sometimes things are the same. But the UK model is quite unique because pharmacists, they do many services, many clinical services. They are integrated in this primary care network, so help doctors, GP, to make a lot of different functions. They have the prescribing authority, and also they can, even if a pharmacist is not a prescriber, because you need to do the old generation like me need to do a course. Now it's different, and I will explain later. But the old generation needed to go to uni and make a course. But even if you are not a prescriber, still the NHS service allows you to give prescribing medication for specific medical condition for some cohorts of patients. And this is called pharmacy first service. So that you always remember that for some condition, always go to the pharmacy first, because they are the first point of access for specific, very simple condition. And this is quite unique. So this is a very interesting slide, I think. In England, we have different digital tools where you can analyze your population. You can see what sort of medication are prescribing, what sort of clinical condition they have, and you can go broader, like my area against the nation, or I can go to check a primary care network, or I can go and see a GP practice, and I can even check also every GP prescriber what prescription they do. This is, and my job was also to do a lot of data analysis and understand the population and doctor prescribing. An example, on the top left, that one show the prescribing of apixaban, the DOAC, direct oral anticoagulant apixaban, in my area against the nation. Why I put this example is because apixaban in England for the NHS is first line. So because it's more cost effective, is less price for the NHS. So my job was to understand, okay, so who is not prescribing apixaban in my area in GP practice? And so by doing that one, I can then understand who is doing or not. And then I think, okay, there are many that are not prescribing apixaban. Let's do an incentive scheme. Let's pay a little bit doctors and say, oh, if you move from maybe edoxaban, that is third line, to first line apixaban, I'll give you some money. And you play with this game. The same with the statins. The top on the right is show the level of low and medium intensity statin prescribing. For example, in my area against the nation, what are low and medium intensity statins? So they are like, for example, fluvastatin or pravastatin. They are not very aggressive on reducing non-HDL cholesterol. So for NHS guidance, a good statins reduce at least 40% of your LDL or non-HDL cholesterol. So my job was, okay, analyze who is prescribing fluvastatin or pravastatin, and then, okay, we are very high. Do you see the red? Not good. So incentive, Marco, think, how can I do? Okay, let's do a scheme. I'll pay doctor, and I'll say, if you prescribe the first line choice for the NHS, which is atorvastatin or rosuvastatin, which are high intensity statin, I'll pay you a little bit. And as you can see, when I did the job, boom, it went down, all the low intensity statin. A little incentive to enable changes for the community. And then you can see many different examples, like at the bottom, broad spectrum antibiotic or PPI, and you can always check. So the pharmacist, usually in GP practice, also do this work, analyze how is their their prescribing in their GP practice. But my job was to make sure that I was making changes for the community to improve. Yeah.
explain. いきますか。これあれですね、オープンプレスクライビングっていう、オックスフォード大学のベネットインスティテュートがやってるみたいなんですけど、データのアナライズをモックさんされてるっていう話です。左上が、アピキサ版の、がファーストラインになっていると、NHS です。それはなぜかっていうと、工業化薬の、やっぱりコストエフェクティブで、やっぱりコストが、エフェクティブ考えて、で、アピキサ版が、いいんじゃないかな。コストとしてもですね。で、他のところから、アピキサ版にチェンジする人に、インセンティブを与えて、そのお金を渡すとかですね、いうのもされてるのかなっていう感じですね。で、右上が、スタチンの話でしたね。アトルバスタチンが、そのファーストラインになってるのに、他のスタチン使ってる人たちを、どんどん移行させようみたいなのが、グラフになってますけど、そういったそのデータをアナライズして、で、ファーストラインの、治療に、どんどんこう、やっぱり、プライマリケア変えていこうっていう活動をされているっていう。
ちょっとすいませんね。皆さん英語大丈夫ですかね。ちょっと後から来た方でスライドが欲しいという方もいらっしゃるので、ちょっと、スライドだけ共有させてもらい、もう一回だけ上げますね。もう一回だけね。はい。あと、せっかくなので、一個、はい。今、英語と日本語のスライドを送りました。あと、チャットの方でですね、一人、質問いただいている方もいるので、少し、インターミッションで、モッタ先生に聞いてみたいと思います。山口さんからですね、臨床薬剤師と GP 診療所の医師は普段から顔の見える関係にあるのかどうか聞いてみたいと思います。So, モッタさん、
Yeah.
Is this pharmacist asking about the communication relationship, face-to-face communication between a clinical pharmacist and a GP surgery general practitioner often?
If the pharmacist work in a GP practice inside with doctors, maybe they can have a face-to-face and discuss with the doctor, or they can just send a message to the doctor and say, I reviewed this patient and I think we should change this patient. It depends from doctors and the relationship. If in my case, I was outside the practice because I was working for the NHS. So basically I was doing some research outside and then send a document to the practice for then the practice work. But yes, inside the GP practice, or face-to-face, or by messages, or spreadsheets, Excel, pharmacy extract the data and send the spreadsheet to the doctor with their consideration. Like this patient, I think we should change it. And the doctor then discuss and say, yes, fine, or no. But then they always communication.
Yeah. Do you mean that in a practice means so hired by GP or the same group belongs to the same group?
Yeah. So I will show later. There are pharmacists working in one single GP practice, or there are pharmacists working in the primary care network. So maybe in 3-5 practice. And they work in everyday different practice.
Okay. ということで、なんか3パターン言ってくれたんですけど、一つはそのプライマリケアチームとして、GP って家庭医たちなんですけど、診療所の中に一人いて、診療所の社員として雇われている場合は、薬剤師さんと同じこれ社員さんなんで、メッセージを送り合ったりして、ここの処方こうなってるよみたいなの言えると。もう二つ目がもうちょっと大きい、地域のですね、プライマリケアネットワークの中にあって、同じ地域の中の多職種連携みたいな感じで、処方行為に関してコミュニケーションを取ると。で、最後はモッタさんがやってたとても大きな仕事で、その軍全体の NHS の処方行動を、コントロールしている立場の人なので、これはちょっとメールとか、 まあメッセンジャーとかでバーッと言うわけじゃなくて、まあ今あなたの処方が全体の中でこうなってますよみたいなレポートを、GP の診療所の方に送ると。そういうのもあるというような、そういう3パターンあるよっていう説明でした。はい。じゃあ、戻しましょうか。では、ちょっと、はい、また戻ります。
Okay. The next two slides are just to explain which are the authority that check and control and support pharmacists and also community pharmacy and healthcare in England. I'm not going to explain all because if not, it takes 5-10 minutes only for one slide. But it's just to show you that there are different components where pharmacists follow or are part in order to do their jobs. This is a little bit more generic about also for clinical guidance or for who control GP practice or decide which drugs to use or not nationally. And instead, the next one is they are the authority that try to support the community pharmacy to give more money to community pharmacy from the government. Is try to negotiate with the government a good contract. And these are the main for a group or association. Next one is just explaining some of the roles of pharmacists in England. So there are quite a lot. We have quite a lot of pharmacists doing many different things. There are the community pharmacists. There are the prison pharmacists. I used to work in 3 prisons many years ago. And prisons have also a pharmacy and also pharmacies that they help a doctor to check for prisoners. Then there are hospital pharmacists. There are the juniors, the one that they just start. There are specialists, like you can have a specialist doctor in antimicrobial, in cardiology, in respiratory, in musculoskeletal, or mental health. And then more you get advanced, you become a consultant, which is the highest pharmacist in hospital, which is at the same level as doctors. Very respect as well. Then, like I said previously, there are the primary care network pharmacists, which the government gives some money to recruit these pharmacists in primary care networks. Primary care networks is potentially maybe 2 or 3 GP practice or 10 GP practice, 5 GP practice, depend from how population they cover. Usually between 30,000 to 50,000, you create a primary care network. And there you have different GP practice. And pharmacists work in this primary care network and they, for example, make these audits or double check patients monitoring. So they check are the patients that are on this medication or this condition having the right blood test made. So they make searches, identify this patient, and they support the doctors. Pharmacists or prescribing pharmacists are not to take the job of doctors, are only to support the doctors and support the community to give the best care. And then you have...
うん。これは向こうできたら表の持ってきてるわ。
いい方です。
うん。
ご飯にしていいですか？
お願いします。
聞こえてます。
続きます。
すみません。声を、ミュートにお願いします。ごめん。
Okay. And then there are other pharmacists, the GP practice pharmacists, the pharmacist independent prescribers that can also do some private jobs, private as well. And the pharmacist in the national system, like in the England system, in the area system like me, or they are called medicine optimization pharmacists. They make a lot of audit or guidance for doctors or creating policy. So there's many type of pharmacist. This is to explain what is independent prescriber, which is unique in the UK. So we have the same legal prescribing powers as doctors and nurses, and we can run clinics independently. And we work with a multidisciplinary team to accomplish this big task. Of course, it's not that when you finish school, you go and prescribe everything, because if not, you can create harm to the population. So you need to feel confident in the area that you want to cover. And when you do your training, you training potentially in one area. Like my training was in cardiovascular. I did clinics in hypertension, atrial fibrillation, and heart failure. So I started doing clinics for this type of patients. Then more you do courses, more you learn from other doctors, and more you feel confident to take new challenges and prescribe other medication and other diagnosis of patient. And this is how previously the old generation course was a program part-time, 6 months. You needed to find a doctor. Like I needed to find, for example, Yoshida Sensei, and ask, please, Yoshida Sensei, please, can you be my doctor? And can I stay with you 90 hours? And you teach me, and I learn about hypertensive patients, atrial fibrillation cases. And then you do your exam, which are different tasks, and then you get the qualification. Now, from this summer, every student that finish university are all independent prescribers. So independent prescribing course is part of your university course, and you constantly learn about prescribing and patient. And so when now the new pharmacists finish and become qualified pharmacists, they have the skill to prescribe without doing other courses. It's part of the course. And this is a new change because they realized that pharmacist prescribers are really useful for the community. This started 23 years ago, but very limited. It's not that it started like big. It started as a supplementary prescriber. So you were able to do little adjustment, like adjustment of one medication strength to a higher strength, or you were able to do little minor condition diagnosis prescribing, very small. After a few years, this is really good. And they expanded and they become independent. So, like I said, they cover why is useful this course and this profession, because it's got a big impact and benefit on primary care. It reduces the general practitioner workload, so the GP can focus on very complex patient instead of simple minor ailments. they can see faster care, because in England, doctors, they maybe are so busy. NHS is very busy. Doctors are really busy as well in GP practice. So you maybe Monday morning, you ring your doctor or GP practice. Doctor, please, can I come? I feel, they say, well, no, maybe tomorrow, maybe in 2 days, maybe in 5 days, if it's not too urgent. So they're like, okay, go and see a pharmacist if it's for this condition. So it's gives more access to care for patient. And if you go best access to care and good medicine, your patients improve faster and they feel better. And also the pharmacist in this role can also review a lot of polypharmacy and reduce harm of medicine. This slide is really interesting because before coming to Japan, the title was different. Was why Japan should consider independent prescribing course. But I think, like in England, they should start giving a little bit more responsibility to pharmacists and see how it goes and do some trials. And because with your aging population, with your high chronic disease, and there's a pharmacist everywhere. So see a pharmacist will be really good and access will be really strong for the patient. So maybe start small, like we did in England, and then see if it gives benefit. And this is what me and my friend in Okinawa, Tamaki-san, we were discussing. Why don't we think to do something, a little test? So this is something that I want to help in case. I'm really interesting. So before I mention pharmacy first, so this is a national service funded, so the money are coming to community pharmacy from the NHS to provide pharmacy first service for these 7 conditions, for headache, impetigo in kids, infected insect bites, shingles, sinusitis, sore throat, and UTI. So you don't need to be a prescriber for this prescription-only medicine. So the national system and previously the local system, which Cornwall first created in a very different, unique way, is you have a document pharmacist that has been created by your government, which you read and it gives you all the direction how to treat these patients. Then you sign, you take responsibility that you understood, and for every patient that come with that condition, you can do a consultation, and then you can treat the patient for this condition. And the consultation is sent electronically to your GP practice. So your doctor knows about your consultation with the community pharmacy. Do you want to?
Okay.
Yeah.
ここを解説させてください。この PGD っていうペーシェントグループダイレクションっていうのが、ごめんなさい。すごくいいシステムらしく、そのフローチャートがあるらしいんですよね。その対象となる7疾患に関して、特に尿路感染症とか、ですけど、フローチャートに、セプシス、敗血症の疑いのあるケースとかも、高熱があるとか、感染率があるとか、そういうケースを除外できるように、そのフローチャートがあって、で、それに当てはまるコンサルテーションが必要になっているケースは、ドクターに紹介するっていう感じで、住み分けがなされているのと、コンサルテーションも、迅速になって、ドクターとしても助かりますよね。そういう情報が事前にあるっていうことはですね。っていうシステムでされてるっていうことです。
These list are other examples of service that community pharmacies do, funded, so money coming from the National Health Service. So hypertension case funding. So a patient 40 years old or older comes to the pharmacy, and the community pharmacist can do a high blood pressure check, and then they can do a test and then send the information to the GP practice about, oh, I found this patient with high blood pressure. And so they flag this patient to the GP to be reviewed. They do smoking cessation, so to stop smoking. They do new medicine service. Imagine a doctor change or add a new medication. So the community pharmacist can ring the patient for 3 times to double check that everything is fine with the new medication. We do vaccination. So pharmacists in the UK do vaccine a lot. They're actually the main vaccinators are community pharmacists. They help a lot the system. And they do emergency supply service. So if a patient on Saturday or Sunday, for example, has finished his medication, can go to a community pharmacy and they can have a few days of extra drugs to cover the weekend, for example. This slide instead is some local services that we actually do in Cornwall, which are a little bit more different than national. We give more power to pharmacists to do other medical conditions like vulvovaginal candidiasis, migraine, more skin condition, otitis externa, or bacterial conjunctivitis in kids. We also do emergency contraception, sexual transmitter infection testing. We do provide palliative care medication. We do specialist medicine like COVID medicine or flu antivirals in outbreaks in care homes. We do a project, it's called Timpa Health. So some pharmacists have this device attached to a phone, and they can see inside the ears, and they can also extract the wax, so do wax services. And also they can do Map My Mole. So they are given a special phone, and the pharmacist can do picture of a mole and videos, and automatically doing a little consultation with the patient and send to a team in the NHS of dermatologists that then does the diagnosis and advise the patient what to do or not. In England, we have digital integration, so electronic prescription service. So the doctor send the information electronically to the community pharmacy. The community pharmacy then download and print basically this script. There's quite an interesting difference. A prescription in England lasts 6 months. Here, only 4 days. Instead, for controlled drugs, 28 days. That is a difference. But yeah, our prescription lasts 6 months. Also, there is a system called electronic repeat dispensing. So imagine a doctor has a patient that is very stable, always with the same medication, very simple, same blood pressure medication, or same levothyroxine, or same inhalers, and the doctor feel is always the same. So the doctor can create this repeat, like a refill prescription that goes for 6 months or 12 months up in the matrix, in the matrix. And the community pharmacy, July, download. August, download. September, download the prescription. So the doctor doesn't need always to do prescription for this stable patient. Of course, not for every patient, but for stable patient, this is it takes a little bit less pressure for doctors to spend time to do prescription and more to see patient. And then we have interface with the GP practice, community pharmacy, and hospital records. In some area, little bit less. Some others is very advanced. So there's still a lot of work to do also in England. So this is Cornwall, and I'm going to explain these two projects that we do. So one is called walk-in consultation service. So a patient can walk into a pharmacy and have a consultation like with a doctor. They go in the room and they have a consultation. They discuss some clinical condition, not very simple, a little bit more complex, and they can then decide how to triage the patient. The patient need potentially to be used the PGDs for the pharmacy first, or if a prescriber, he can prescribe a medication, and then all the information go to the doctor. This service was discussed in government with the ministry, and then Pharmacy First National was then established, taking a little bit of auditing from Cornwall. So we are the Cornwall supported the national service. And the other one, we are doing a cancer pilot. So the pharmacist see a patient in his consultation, and the patient, for example, tell him, I'm coughing blood, or I'm passing some blood from my stool, or my skin, I'm a little bit worried about my mole. So we have created a checklist for pharmacists to ask a specific question to these patients that they can have. There are many different types of cancer. So we are covering the main cancer. And basically, we are giving the pharmacy a checklist. They score the patient with the checklist. Every potential line has a score. Like imagine the mole on your skin has changed shape or has changed color. You give a high score or less score. This is all in your guidance. And then based on the score, you send or to hospital or to the GP practice. And in this little trial, we see that doctors and pharmacists have the same rate of identification as the same as in the national statistic, between 5-6%. What does it mean? It means that if a patient discusses with the doctor or discusses with the pharmacist, the rate of identification is the same. It means that the pharmacists are also doing a good job in preventing or identifying cancer at early stage. And we want to show all this one to the nation, our final data. This is the last slides, because it's nearly 7. You're probably very tired. But this is football. Yes, England and Japan football. So in my discussion, basically, I wanted to show the strength in pharmacy through our a lot of clinical skills, a lot of national services, our independent prescribing authority, the strong relationship with the primary care teams and our digital analytics. And instead, from my learning, in Japan, you are very precise, very high quality. The public trust pharmacist. You are a lot of robotics. You have a strong academic and research culture, and you have a highly structured community health system, especially with all your local clinics, which is very different than the United Kingdom. We don't have, like you, all these specialist clinics. But I think that we can share opportunities for grow together and expanding. I can expand and take some of your services, and you can expand and take from our services. And I think the last slide is that pharmacists are essential. England has shown a very powerful model. Cornwall, he's unique because of he's very remote. So we tend to try to do things slightly different than the nation. Therefore, Japan can also hopefully elevate the pharmacist profession, because pharmacists are not the future, but are the present. どうもありがとうございました。
すみません。本当にありがとうございます。もう、とにかくですね、やっぱりGP を支えるシステムっていうのが、本当に確立されているということですね。簡単なケースに関しては、もう、GP の診察なしに、インディペンデントプレスクライバーが処方ができる。で、複雑なケースに関しても、チェックリストを活用して、コンサルテーションをしっかりするシステムが整えられているということですね。先ほどのコールの独自のシステムだって言われてましたけども、癌の早期発見、その血便とか、スキンリージョンの、発見で、チェックリストを用いて、スクリーニングをして、で、どこにつなげていくかっていうのをこう決めていくっていうのも含めてされているのは、本当にすごいなと思って聞かせていただきました。ありがとうございます。Thank you very much.
I just want to say thank you to the International Committee of Japanese Primary Care Association to inviting me in Japan, to Tamaki-san in Okinawa Midori Pharmacy, and to Yoshida Sensei and his hospital and his president that is here with me today. ありがとうございました。
はい。
はい。
いえいえ、ありがとうございます。玉木先生、なんか一言ありますか？お声出しいただいても大丈夫ですよ。難しい。ちょっと空港にいるような気がするんですよね、玉木さん。大丈夫？
はい。空港のブースでもうあと5分。ちょっと
何か喋ってください。
はい、2週間っていうか、10日ぐらい、過ごしていただいたんですが、なんで沖縄だって東京とかね、大阪、名古屋とか大都市でいいじゃないかって言ったんですけど、彼のコンウォールが、いわゆる沖縄に非常に近いような雰囲気だったっていうことで、むしろ喜んでくれてました。それから特別なものというよりかは、一般的な日本の普通のコミュニティファーマシーの、フローっていうのを知りたいということで、私でも役に立てるということで、引き受けさせていただいて、うちだけじゃ代表できないので、もちろん薬剤師部会から尾身川先生はじめ竹内先生二人わざわざいらして、大都市というかですね、都会の方との違いもサポートしながら、そして久米島の方にですね、海外で薬剤師の方をやってた方が薬局されてる山城明さんという方が久米島の方で薬局やってるんですけど、そこにも訪れてですね、短い間だったんですけども、沖縄、それから当初医療ですね、それから、大都市圏のところの紹介しながらという形で2週間、過ごしたということで、最後、コミュニティファーマシーの話してますけど、GP プラクティス、クリニックがないんですよ。街の中に。専門医スペシャリストがいなくて、全部 GP を通ってから行くというところが、すごく印象でした。必ず GP を通ってからスペシャリストに送られるので、すべてヒストリーが、患者の背景をすべて一人のGP が把握していて、で、そこに薬剤師が絡んでいくという仕組みなんですね。なので、ぜひ先生方、これ、 ね、最後のカルテじゃないですけど、GP プラクティスの方の、そのジェネラルの方ですね、やっぱり日本で方でもすごく重要になっていくんじゃないかと思いました。ありがとうございました。すいません。
はい。玉木先生、ありがとうございました。それではちょっと時間が過ぎてはいるんですけど、せっかくたくさん質問いただいているので、チャットの質問や、あと会場の皆さんの質問に答えていって、だいたいあと15分ぐらい延長しようかなと思います。で、スライドはですね、日本語と英語も、チャットに、上げているので、必要な方はお取りください。で、もちろんですね、次のご予定とかお忙しい方がある方は、ご退席いただいても結構です。チャットの質問、まず会場からご質問ありますか？チャットの方は5つぐらい溜まっているんですけど。大丈夫ですか？また会場も聞きますね。せっかく海田病院メンバーや薬剤師の皆さんもいらっしゃるので。一つ目の質問が、葛西先生からで、How are NHS pharmacists involved in the training of GP trainees? どうです？ Yeah, this one.
Yeah, as part of my role before, I was doing lessons to GP trainees, also students, about pharmacists and about medicine optimization, how to prescribe better medication, the national guidance, the local guidance. It was part of my role as well to support, but also the community pharmacist and pharmacist in GP practice always are linked together. When a student, a GP student, isn't in the GP practice doing the train, they also collaborate with the community pharmacist or with the pharmacist in hospital about understanding their work, their system, and to help each other, because there's a lot of appreciation for the job of pharmacists and their knowledge. So it's part of a multidisciplinary learning that doctors do.
はい。ということで、葛西先生の質問はですね、家庭医のその専攻医たちに薬剤師さんはどうやって教えているんですかっていうことなんですけど、二つのパターンがあるとお答えされてて、一つはもうとにかく、NHS の薬剤師さんは、国全体の処方ガイドラインと、あとローカルな地方のガイドライン両方に精通してるんですよね。だから専攻医たちにこの場合の処方は、今日皆さん聞いたと思うんですけど、工業古薬のドアック一つ取っても、どの銘柄がファーストラインでどれがサードかとかすごい細かいですよね。こういう違い、使い分けを教えてあげるということ。もう一つは、そのコミュニティファーマシストですか、地域のプライマリケアの調剤薬局とかで、薬剤師が同じ診療所内で働いていることもあるし、近くのネットワークにいることもあるので、その中でもむしろ同僚として、いろいろ情報交換しながら、診療情報を共有して、学び合うという、そういう形があるというお答えでした。はい。で、いいですか、皆さん。なんか会場の皆さんがシーンとしていて、チャットの方ばっかり湧いてるんですけど、大丈夫ですか？じゃあ次行きますよ。じゃあ、next is, this is now Professor Okada from Wakayama University, Wakayama College ね。His question is about, so basically understanding, so is the nice guidelines super important for the basement of knowledge for the prescription in UK? Is that right?
Yes, NICE is the body that helps develop the guidance for clinical condition and advise to doctors or prescribers what to prescribe. There are two different types of NICE. There is NICE guidance, which gives the advice to doctors. The doctors, they should follow what the NICE guidance say, but sometimes the patient is unique, and so you need to go outside what the NICE guidance suggests, but the doctors have the responsibility, accountability, and the knowledge to do that. And then there is a NICE tag that is technology appraisal, which NICE does a study of a new drug or a new medical device, and he tells every area you must implement that drugs or that medical device in 30 days or 90 days. And the system needs to understand how to implement this new drug or new device into their own area. And that is where it becomes very hard for every area to manage this one financially, because it could cost millions of pounds to implement for all the population some medication. An example is the Mounjaro or semaglutide for type 2 diabetes or weight loss. So for weight loss, there are too many patients. So every area need to understand how we're going to implement this ask from NICE to prescribe this for our population. And that is where every system is working hard. So you NICE technology appraisal, you must implement NICE guidance. You should follow because it is the best advice based on clinical evidence and cost for the NHS.
はい。ということで、ちょっと基礎用語の確認でもあるんですけど、ナイスガイドラインというものを NHS が使っていて、まあ、これはエビデンスをもとに、どのお薬が、まあ、お金と効果、費用対効果がいいとかも、まあ、英国なりに調べられ尽くしたようなものなんですよね。だから、まあ、やっぱり確かにナイスガイドラインがあることで、医者たちは基本的に処方行動をこのガイドラインに沿ってやらなければならないと。で、外れた場合は、日本でもその査定ってあると思うんですけど、保険の。なんで外れたのかっていう疑義紹介ってやってると思うんですけど、それに近いことで、なぜこの人でガイドラインから外れた処方をしたのかっていう説明をしないといけない責任があるということ。あともう一つですね、ナイスガイドラインの素晴らしいところは、新しい処方とか、まあ装置とかが出たときに、それをまあ多分これは文脈的にもローカルで言ってると思うんですけど、その地域ごとにどこまで取り入れるのかっていう、その実装っていうんですか、インプレメンテーションっていう、そういうところのやり方とかを取り決めていることで、例えば今回例に挙げていたのは、皆さん痩せる薬としてのマンジャロ。とかがですね、非常に出回ってるかと思うんですけど、でも、痩せないといけない人って山ほどいるので、全員にいきなりそれを適用したらお金がパンクしてしまうと。なので、まあ、この地域では、マンジャロを、肥満症の人のこういう人にこういう感じで始めようと。まあ、60日、30日とか90日とか、30 days or 90 days. Is that trial days?
No, you must.
Must. Only 30 days or 90 days.
Yeah,
It's
there
a
are-
limitation.
most is 90 days,
Okay.
but can happen sometimes further. But mostly drugs or medical device, 90 days you must implement.
OK。例えば何ヶ月もいきなり処方とかできない。まあ、90 days だと30日は、3ヶ月結構長い気がするんだけど、まあでも、まあ、それぐらいとか、そういう制限をかけてちょっとずつ新しい医療技術、薬を試していくっていうのもあると。まあ、なので、ちょっと岡田先生の後半の質問にまでは答えてませんけど、まあ、カナダで岡田先生が留学した時、アップトゥーデートを調べるっていうのとは、やっぱりこの実装っていう意味で、実行力っていう意味で、だいぶ違うかなっていうのがナイスガイドラインの特徴です。皆さん、すぐに、ググっていけばですね、もう公開されているので NHS のガイドで何か処方行動の勉強の時とかに参考にしてください。では次に行きます。はい。じゃあ交代します。はい。では、ムタ先生です。
ムタ先生からご質問ですね。日本語でいきます。
日本語はもう書いてあるからいいんですか？
そうですね。会場の方おられるので、はい、まあ、簡単に言うと、まあ、薬が、英国では、まあ、種類が限定されてて、まあ、それが処方しやすさにつながっているというのを聞かれたことがあると。で、その事実が影響がありそうですか？まあ、日本の薬が多すぎるので、まあ、ARB だけで6、7種類とかあって、それが、ちょっとまあ、処方、何すればいいのかっていうのの、選択で迷うみたいな感じにならないんじゃないかっていうご質問です。Is there a limitation of some drugs by the government NHS of the medicines by the cost effective or the affection and so maybe such as like ARB is limited only on some drugs.
Yeah.
And so Japan he thinks Japan has a lot of drugs, ARVs, 6 or 7, 8 types. So we sometimes confused about how to prescribe which drugs. So that it the limitation of drugs facilitates the prescription of NHS. Is it
Yeah.
true?
Yes, the doctors in theory, a doctor can prescribe everything they want, but the NHS, because they need to limit a little bit what medication to prescribe as a first line choice, second line choice, because if not, it becomes too expensive and too much chaos. So the guidance usually they give the direction for 2 or 3 medication in that family. Then of course the doctor can decide based on each clinical case which one is best. But the direction is to limit the option to a specific 2 or 3 medication. Sometimes area implement maybe different choices because the clinician in that area thinks no, I think it's best that one or another one. Part of my job was to chair the committee to decide which medication we prescribe in Cornwall for that condition. First line, second line, and that's it. So it was part of my role. But yes, we try to limit for clinical evidence and also for cost effectiveness for the NHS. Because the NHS is free. So that is slightly different than in Japan.
ありがとうございます。おっしゃる通りですということです。やっぱりコストエフェクティブのところと、やっぱりその臨床のアウトカムを、重視して、やっぱりそれぞれのクリニック、ないし薬局で、使うお薬は、メインのファーストライン、セカンドラインとかに考えると、2、3種類っていうことで、言われてました。ただ、それが、やっぱり地域によって、それは変わってもいいんじゃないかっていうのを、研究されていると。特にコーンウォールで、どういうお薬が、ファーストラインで、いいのかとか、セカンドラインでいいのか、他の地域と違うんじゃないかという状況を把握して、さっきのそのデータから抽出して、それをアウトカムに活かして、じゃあこれをっていう、このリコメンドを、する役割をしてますっていうことですね。
結構、一昨日ぐらいから飲み会でずっと喋っててもそうなんですけど、どうやって、臨床家たちの処方の裁量を少しは作るかみたいな、圧倒的に多分日本に比べて処方できる、幅は狭いんですよね。だけど、そんな中でやっぱりどっちもいい場合はどうかみたいなのも一応考えてはいるという、そういうことでした。では、あともう一つぐらいかな。南郷大輔さんからですね。尿路感染症に対して、so, yeah, who is a big role to prevent so resistance of antibiotics regarding the initiatives from pharmacists in UK?
Yep. Yes, antimicrobial resistance is one of the key area where pharmacists are involved. Some of the consultant or specialist role in hospital are for pharmacists that they can only cover antimicrobial resistant, and they make audits to review the prescribing of doctors. In GP practice, they run searches pharmacists to identify the trend of prescribing for patients for a specific clinical condition. And my role national is to run data and in case challenge the doctor on their behavior. Imagine, for example, a patient is constantly ordering a rescue pack for his COPD, maybe 6, 8, 10, 12 times a year. That one, it means that his COPD is not well managed. So what the pharmacist they can do is run a search to identify those patients and then flag to the doctor. Or they can run a search to identify patient with a short-acting beta-agonist SABA like salbutamol. Imagine a patient that constantly order 10, 12 times a year Ventolin, which is quite, and it means his asthma is not well controlled. And that one trigger infection, exacerbation, and also UTI. We tend to do a lot of audits for UTI, especially nitrofurantoin, trimethoprim, or broader spectrum antibiotic like coamoxiclav, fluoroquinolone, or cephalosporins. So these are really part of the NHS agenda and the World Health Organization that we must reduce antimicrobial resistance. And pharmacists are the key to this role.
So, do you have the information of a local drug-resistant chart?
Yes.
You also another data.
Yes.
Do you merge into one?
Yeah, we work with the public health of our area and the hospital to understand the trend of resistance. So sometimes it can happen that the resistance in our area is slightly different, and therefore maybe the doctor tend to prescribe it in different way. Or in our case, we are very rural, very remote. Imagine a patient going in a GP practice far from hospital, and if he gets an infection and is not prescribed enough, maybe risk sepsis. So you need always to balance the patient in front of you. What is best for the patient?
Okay. ちょっとすみません。このご質問は薬剤師が、特に抗生剤の多剤耐性対策にどのように寄与しているかという話なんですけど、大いに寄与していると。一つは処方行動からちょっとまずいケースを見つけるっていうことがありまして、ちょっと COPD の例は話してたんですけど、感染症じゃないので省きます。はい。だから尿路感染症の人がいて、その時にある、家庭医が、もしくはある病院のある先生が、広域抗菌薬であるフルオロキノロンとかセワロスポリンを連発しているというような場合は、この人の処方行動が、多剤耐性菌を作りかねないので、そこは、処方行動のデータからチェックして、で、指導を報告で入れていくみたいなのがあるということですね。あと、ちょっと僕は、地域の疫学科とかに聞いて、それぞれの地域ごとの、多剤耐性抗菌薬の状況とかと付き合わせるのかって聞いたんですけど、ちょっとあんまそこは答えてたのかなよくわからなくて。ただ、結構地理的な問題に関しては寛容にならねばならないと言っていて、例えばもうすごい田舎の方の家庭医が、とか、離島にいる家庭医が、患者さんが動けなくて感染症で何かできる抗菌薬を投与している場合、で、それが敗血症とか重症化を防いでいるような場合は、そこまでチェックを入れて止めてしまうと、その方が結局悪くなっちゃうかもしれないので、その辺はバランスだなっていう、そういうお話をされてました。すごく臨床的ですよね。で、じゃあ次は、ちょっと、長くなってきているので、イギリスの薬剤師独立処方は疾患領域限定はあるんですかっていう話は石井先生から来てますけど、これは先ほどのスライドの中であったように、それぞれのその指示書とかトレーニングごとに限定してやるっていう話でしたね。はい。なんでこれはお答えとさせていただきます。で、じゃあ次は、じゃあここまで私がやって、最後のやつを橋本先生で一応終わりにしようかな。はい。で、じゃあ、石井先生もう一つありがとうございます。この薬学部卒業者のすべてが卒業できることになったアウトカムは何なんですかってことですけど、So you mentioned about since 2026, mostly of the pharmacist graduates can prescribe because of the new training inside the college curriculum. So that do you already have some good outcome, healthcare outcome in UK after this initiative?
The prescribing, all the students are coming out now, so we don't have any sort of data at the moment. But we have been running the project around independent prescribing for pharmacists for the last 23 years. So 23 years of pharmacists doing the course and becoming prescriber. So because the NHS and the healthcare trust the pharmacist, now the idea was to implement already in the university the course so that everyone can become already a prescriber. So the outcomes of the benefit is there, and this is why it's now part of the university. And sometimes, in terms of antimicrobial resistant, can I say something else? Community pharmacists play also a vital role in antimicrobial resistant. We see that by doing the pharmacy first service and the patient going to see a pharmacist for UTI or for other clinical condition where you need to prescribe an antibiotic, the system is now prescribing slightly less antibiotics, because when you go to see a pharmacist, they have a very extreme checklist of they need to fit a lot of criterias, and that one reduced giving antibiotic out. And that one show slightly little bit less.
Not for the viral condition.
No, for the bacterial.
Okay, okay.
Yeah.
ですね。一つ目の質問なんですけど、確かに考えてみると2026年からなんで、まだ卒業したばっかりなんで、はっきりその国として全ての薬剤学生が処方できるようになったかどうかはわかんないけど、背景としてかなり NHS は、薬剤師たちにそれだけの期待を置いてくれているのと、処方行動を良くして、国のヘルスケアを変えてくれるんだろうという期待があると、そういうようなお答えでした。あともう一個ですね、ちょっと思い出したように、先ほどの多剤耐性菌に対する対策はもう一個あると。で、お話の中盤にあったように、その薬剤師さんたちのウォークイン外来というのがありますね。その様々な病気でかかって直接見てもらって、薬剤師が処方できると。ただ、その時のチェックリストは非常に厳しくて、例えば、風邪だと思われたものに簡単に抗生剤を出さないように、かなり厳格に、規定されていて、本当に基準を満たした時だけ、例えば、溶連菌に間違いない、溶連菌性の咽頭炎だということが分かった時に、初めてペニシリンを出すとか、そういうチェックリストになっているんで、これも多剤耐性菌予防に役立つであろうということでした。じゃあすいません。なんかだんだん、学術大会のセッションみたいなでなんか終わらない。でもみんなが、ごめんなさい。ちょっと、チャットの方が熱くなってるんで、あと2個は頑張っていきますね。じゃあ次、はい、橋本先生お願いします。で、最後、勝西先生の質問です。
はい。じゃあ、山口先生ですかね。からのご質問で、英国では看護師は、独立処方できるのでしょうかということで、in the UK, in the NHS system, can the nurse prescribe independently for the patient or not?
Yes, the nurse can also prescribe, like a doctor and a pharmacist. There are two types of nurse prescribing. There is the supplementary prescribing, which is a little bit limited, or you are an independent prescribing, where you can prescribe everything like a doctor. So, yes. So also there are physiotherapists that they can be a supplementary prescribing. So they can prescribe, for example, painkillers for their patients, or there are for example, there are other like paramedics that they can prescribe, podiatrists, the specialist of the foot, can potentially prescribe as well. Now, dietitian and speech and language therapists are working towards to be prescriber as well, all in very specific clinical area and a very specific medication, not everything. But nurse, doctors, and pharmacists have the same range of prescribing.
本当に特定の、ごく限られたお薬に関して、医師の監督のもとにだと思いますけど、サプラメンタリーで、補助的に処方できるシステムがあると。日本のその指示医薬の処方に近いシステムだと思うんですけれども、それのシステムが、驚いたんですけど、看護師だけではなくて、フィジオ、セラピスト、PT さんとか、他の、医療従事者の方々も、そういったのを活用できるシステムがあると、処方できるシステムがあるということなので、本当にごく限られたスペシフィックな特定のものになるということでした。はい。
なんか話してたんですけど、どうやら ST さん、言語聴覚士さんも処方できるようになったんだけど、その時は、褥瘡だったか。じゃあごめんなさい。フィジオセラピストと褥瘡だったか。なんか褥瘡を見る人が褥瘡の抗菌薬だけ出せるとか、なんかサプリメンタリーっていうのは何か特定の疾患でその人がよく見るようなやつで、そこの処方を、医者に断らずに自分でできたらいいじゃないか、みたいな、そういう感じで出てくるみたいですね。ただけど、とにかく医者とナースと、あと、薬剤師の3つは同じ処方ラインに並んでいて、より幅広く処方権を獲得できるような立場にあるということでした。で、じゃあ、ちょっとすいません。ちょっとフォーミュラリーの話とかあるんですけど、ちょっともう時間が結構あれなんで、最後、葛西先生のご質問で締めたいと思います。This is English ね。なので、僕は日本語で言いますね。これはですね、ちょっと逆に処方じゃない生活指導的なものとか、あと、精神療法とかに関して、GP、家庭医と組んで、薬剤師が、どのように、患者さんに提供したり提供しようとするのか教えてください。
Yeah.
He is a professor of the previous professor of Fukushima, the founder of Japanese family medicine.
Okay.
Our father.
Oh, wow.
Yeah.
どうも、こんにちは。
こんにちは。
こんにちは。龍谷葛西先生。こんにちは。The doctors or prescribers use social prescribing now. So, as part of your area, I say that our area is broken in different little areas. In every little areas, many things happening as a voluntary sector. So there's many organization and association helping patients with holistic approach. So the role of doctors, pharmacists, and the system is to use social prescribing to direct the patient to these services, to help the service, to help the patient using the service. An example, in Cornwall, we created a pain cafe for addiction of pain. So every little area, 16 areas, have a pain cafe where there is a pain cafe leader that help patient that they are sent by the doctor to do the 10 steps of the program in order to reduce the prescribing of opioids or other benzodiazepine or gabapentinoids, and using also meditation, yoga, and this is all part of social prescribing and holistic approach. I hope it answers the question, Ryuki Kasai sensei.
ということで、キーワードはやはり社会的処方、ソーシャルプレスクリプションということなんですけど、地域、それを小分けにどれぐらいの地区にしていくかということはあるけど、様々な、ヘルスケアに関する団体、それはボランティア団体とかも入るんですけど、みんなですね、地域資源をそれぞれの患者さんに対して、これ使ったらどうっていう、ここに行ってみたらどうって紹介してあげるという空気が、空気じゃないですね。そういうシステムが必要だということで、例えばコーンウォール独自でやっている取り組みとして、ペインカフェというものがありまして、これは慢性疼痛の人たちが、ともすれば、じゃあオピオイド使おうと。麻薬使って抑えてきゃいいやって言ったら、今度はそれで薬物中毒になっていくわけですよね。だからそれを減らすために10段階のちゃんとステップがあって、で、これに沿ってみんなで紹介していって、各所にあるペインカフェに行って、仲間と一緒にヨガをやったり、なんて言うんですかね、カウンセリングみたいなことをやったりですね、そういう非薬物的な療法を一緒に受けていくことで、結果的にそういう人たちに対するオピオイドの処方が減っていったり、そういったお薬から解放されたりっていうのを目指すというものでした。素晴らしい例えでしたね。はい。さすがですね、モッタさん。すごいですね。はい。ということで、すいません。ちょっとまさか90分セッションになると思ってなかったんですけど、ちょっとここで一旦締めて、会場からの質問をお受けするかもしれませんけど、とりあえず、ネットの皆さんには、はい、ここでご挨拶をしたいと思います。So, again, so thank you very much for your wonderful presentation, Mr. Motta Marco, and your clever and kindness. Thank you.
Thank you. Thank you, everyone. さよなら。
バイバイ。See you. チャオ、チャオ。
チャオ。
ということで、バイバイ、everyone。
バイバイ。
バイバイ。もう、先生すいません。飛行機大丈夫なんですか？それ帰れるんですか？どこにいるの？
もうあと5分で登場です。
ちょっと乗り遅れないでくださいね。
大丈夫です。
気をつけて。
はい。チャオチャオ、バイバイ。
チャオ。
富川先生もありがとうございました。